My name is Janet Beyer. I'm one of the administrators of the TVT-NO organization, and I will be hosting this conference call today. The topic of our call will be women's pelvic floor physical therapy. Before we begin and before I introduce our guest expert, I'd like to outline a few technical details of how the call will work. Under the Files tab in the Q&A group and also in the main group, we have posted a series of handouts and drawings of the female pelvic anatomy, including detailed drawings of pelvic muscles and nerves. We may refer to these during the call, so feel free to open these files and use them as a reference. I'd also like to reiterate that TVT-NO and most mesh removal surgeons recommend physical therapy for those who have had their mesh fully removed. And with that, I'd like to introduce our guest expert. Jessica Aubert has been a staff physical therapist at the Beyer Area Mobility Center in Marinette, Wisconsin since May of 2006. She received both her Master of Science in Physical Therapy and Doctor of Physical Therapy degrees from Central Michigan University in Mount Pleasant, Michigan. Jessica specializes in women's health issues including pelvic pain, urinary and fecal incontinence, prenatal and postpartum pain, and lymphedema. Jessica has taken numerous courses in the area of women's health through the Herman and Wallace Pelvic Rehabilitation Institute. And on a personal note, Jessica is the physical therapist who helped me enormously when I had severe vaginal muscle and nerve pain following my mesh sling 3 years ago. So welcome, Jessica, and thank you for joining us today.
Thank you for having me.
You bet. So the first item in our outline that Jessica is going to discuss is what is a women's health physical therapist exactly?
It is all physical therapists are trained in the muscles of the body and how those muscles support various joints or organs, just keep us moving. And women's health physical therapist just happens to specialize in a very private area of muscles, that being the pelvic floor, which is a group of muscles at the bottom of the pelvis. Any physical therapist who wants to specialize in women's health can take their coursework through numerous places. I chose to take mine through the Herman and Wallace Pelvic Rehab Institute because they had a nice variety of things, not just courses related to pain, but some of the other areas I was choosing to specialize in as well. The American Physical Therapy Association also has a women's health section, and so they also offer courses. Women's health physical therapist can be just someone who has an interest in problems that are more specific to women than men. It can be someone who has actually gotten a certification in women's health physical therapy, which then proves that they've had so many patient hours logged that they've treated and they've taken a certain amount of coursework. And then finally you can also get a women's health specialization, and if they have that, they will have a WCS following their name, and that is through the American Physical Therapy Association. That requires over 1,000 hours of one-on-one care with women with various diagnoses that are specific to them, as well as taking a standardized, I think it's like 150 question examination and passing it. So that's the highest level that a therapist could get to prove that they specialize in women's health. But basically it's someone who has an interest in things that are specific to women and has taken coursework in order to treat that effectively and appropriately.
Do you think there are a lot of women's health physical therapists across the country or even in the world? Do people have access to that?
There's not as many as there should be for how many people that have problems. But it is growing. When I first took my basic course, there were 40 physical therapists, including myself, so 39 other physical therapists, and most of them were in the same boat as me. They hadn't taken a course at all, and they were just trying to figure out, is this something I really want to do? You know, can I do this? And in courses that I've been to more recently, there has been 50 to 75 physical therapists there learning. So they are more advanced courses as well, because I didn't retake the basic course, and so that's enlightening to me and makes me hopeful that the field is growing and more people are becoming interested in treating women.
I hope so too. I know most of us that have had mesh complications could really benefit from physical therapy with a specialist like that. So other countries, is it?
There is an international pelvic pain society as well as an international incontinence society, so I have to believe that there are physical therapists who are trained internationally as well. I have not looked into any courses. Usually I have to travel pretty far just to take one in the United States, so I haven't looked at that, but I have to believe that there are physical therapists elsewhere. I do have a resource to find physical therapists that specialize in women's health in the United States, but not internationally. That resource is the Women's Health section of the American Physical Therapy Association. The website is www.womenshealthapta.org, and then at the top of the page there is a title called Our Patients, and if you hover over that, at the bottom of the list is Locate a Women's Health PT, and you can put in your state or your zip code and select a range of how many miles you're willing to travel, and it will come up if there are any. There's also a spot where you can specifically pick pelvic pain as the specialty, so that you're not getting a therapist who just specializes in incontinence or pregnancy-related pain when that's not, the issue that you're wanting to have dealt with.
So all women's health physical therapists don't necessarily specialize in pelvic pain. Some are focused on incontinence and all the other issues.
Right. Sometimes they'll just pick one area that really interests them. I would say that probably the majority of them, though, they might have started with one area that was of interest, but then when they realized, with just this much more knowledge, I could treat this, this, and this and help this many more people, they've taken that additional coursework to treat. Especially incontinence and pelvic pain can go together, so I feel like if they specialize in incontinence, they probably specialize in pelvic pain as well. But if someone, like lymphedema, for example, is swelling from a lymph system overload, often like after breast cancer, the arm will swell. So sometimes if physical therapists do that, they don't get into they don't have any vaginal examination skills, so they might not treat incontinence or pelvic pain or something like that.
Okay. That's a good resource, and we'll make sure to attach that to this recording so that everyone has access to that too.
Sure.
Okay. So under the topic of women's health physical therapy and what a therapist would do, you mentioned that women's health physical therapy helps incontinence, and I just wondered if you could elaborate a little bit on what it can do for incontinence and what type of people could benefit from.
Sure. It can help with a wide range of severities of incontinence. I have had patients myself who started just with severe urgency, felt like they needed to use the restroom all the time but weren't actually incontinent yet. That's the best time to treat it, of course, but often the time we're not thinking about treating it because it's not severe. And I've had people who have been to the point of their bladder is prolapsing and they want to avoid surgery, and so they come to physical therapy to see if that will help so that they don't have to proceed with a surgery. So really anywhere on the spectrum. Obviously the earlier you catch it, the easier it is to treat, the more likely you're going to see a 100% improvement in symptoms. It also doesn't matter the age. That's another question that I often get, like, well, isn't it normal to have muscle weakness as you get older? And, my mom or my grandma had leakage, so it's probably just, I'm getting to be a grandma myself. It's probably just normal. But the oldest patient I ever had was 92, and she had a 75% reduction in her leakage. So, she wasn't 100% better, but that made a significant difference in her life. She was at the point where she didn't want to leave and go out with her friends because she had to wear a Depends, and she had to pack some because she'd probably still have leakage. So it helped her, that was still a big enough impact even at a 75% reduction. But basically why physical therapy can help is because of the muscles. The pelvic floor muscles are a hammock at the bottom of the pelvis, and they have three main jobs, and they all start with S, so it's easy to remember. They're sphincteric, which is the important one for incontinence. They close off every opening that leaves the pelvic cavity, so the urethra from the bladder, the vaginal canal, and the anus. So by being able to close in a circular fashion, which is what sphincteric means, they close off those openings so that urine or feces is not getting out unless you want it to. They also have a supportive function in that they keep the bladder, the rectum, the uterus inside the pelvic cavity, so you're not having a prolapse.
Many of us have had prolapses. That's a big issue here.
Right. So that a lot of times that happens because there is also ligaments that can cause a prolapse to happen as well. So it's not just muscular, but if there is any weakness, that can help support the bladder better and sometimes reduce the prolapse, if not eliminate the prolapse, depending on if it has any ligament component to why it's prolapsing. And then their third function is sexual. They're the muscles that contract with an orgasm. So that's the three duties or jobs of the pelvic floor muscles, and since physical therapists are muscle experts, that's where we come in to deal with leakage issues. The other thing that can happen other than weakness is that sometimes the bladder itself becomes dysfunctional. When I gave the example of the least severe problem where I've had patients who came in just because they were having urgency and didn't want that to progress to leakage, that is often the muscles are likely starting to not support as well as they could, but weakness usually isn't the main impairment with someone with that. It's usually more the bladder has been trained to be overactive, and the bladder itself is contracting all the time when it shouldn't. And so it gives you that strong need or desire to go to the bathroom.
Like a cystitis type thing.
Exactly, a lot like a cystitis, exactly.
Another question that someone posed to me and asked me to ask is, after mesh sling removal, many of women in our group have slings made of their own fascia tissue. There are surgeons that will do that. Prior to doing that, would pelvic floor physical therapy be an option to try first?
Versus having another
sling that put in another fascia sling made out of their own tissue.
Yes, definitely. Especially, in any physical therapist that specializes in women's health and is trained in this is not going to have you have physical therapy if it's not needed. The most important thing is showing up for that evaluation and having that done. That can give you all the information in the world if physical therapy has a chance of helping. Then they can do their examination to find out if there is weakness or a lack of endurance in the muscles, and if that's the case, then likely physical therapy will help. And based on those measurements, how weak the muscles are or how severe the prolapse is, the physical therapist should be able to let you know how much they're going to be able to help you. If they think it's something that would be totally reversible, or if it's only going to help, 50%, so that then you can make a decision, do I want to continue with this conservative treatment option, or should I just, if it's only going to help 50%, is that worth it to me? Maybe I should just have the secondary sling put in.
It just sounds like it's something worth looking at. A surgery is a pretty big deal, especially if you had one already, or even more than one like many of us had. So
right.
I think people should definitely give that a try.
I'm definitely biased in my response, and
well, sure.
my treatment is conservative, but I always feel, and especially if you had already poor outcomes with a surgery, that it's important to remember that sometimes surgery doesn't cure everything, or worse, causes more problems. So if something conservative will help at least some, then you can decide if that's enough to be able to live with
it. It's at
it.
least worth an evaluation.
Right,
definitely.
Exactly. It doesn't mean you have to go 100 times or anything.
I know a lot of doctors, and we've had this problem too, don't want to recommend physical therapy. Obviously, surgery is their thing, and they want to push surgery right away. But
right.
Do you need a recommendation from a doctor to come to physical therapy, or can you make your own appointment?
There are many states that have direct access. I think it's 45 of 50 states have direct access, which means that you could walk into a physical therapist's office and say, this is my problem, can you help me, and they could evaluate you. The problem is that insurance companies have not caught on to that, so if you want it billed through your insurance, you do need a prescription from a physician or a nurse practitioner or a physician's assistant, a chiropractor. You have to have a referral from one of those sources in order for it to be billed through insurance. But if you're thinking, to start with the evaluation just to see, and you're willing to pay cash for that, then you could go without a prescription from a physician.
That brings me to a question about cost. Do you have any idea what an initial evaluation would cost, average, just ballpark?
Usually it's somewhere between $250 and $300 without any insurance coverage or anything, just as a charge. It depends how long it takes the physical therapist to do the eval, but I'm pretty sure that $250 is the lower end.
Okay. Well, that's not much compared to surgery, that's for sure. So, the next item on my list here is talking about chronic pelvic pain.
Sure.
What it is, how it relates to pelvic floor muscle dysfunction, and how physical therapy can help. with chronic pelvic pain? Because most of us do have that to some extent. So.
Sure, and chronic pelvic pain is just like chronic pain anywhere. They've just labeled it to occurring in the pelvis. It means that the pain has been present for more than 3 months. If it's less than 3 months, then it's either acute or subacute. So that is simply what that means, is that you've been dealing with it for more than 3 months. How that relates to pelvic floor muscle dysfunction is that they're one and the same difference, so to speak. Pelvic floor muscle dysfunction is labeling it more as a true pelvic problem versus sometimes people can have pelvic pain, or they might be labeled as having pelvic pain if they have really lower back pain, like lower back pain that's right at the verge of being at the top of the pelvis or the bottom of the lumbar spine, which is your low back, or sacroiliac dysfunction is your SI joint is where that's occurring, and that's where the pelvis meets the sacrum, which is the triangle-shaped bone at the base of your spine. So sometimes people, if the physician doesn't know if it's truly sacroiliac joint problem, they'll label it as pelvic pain. Versus pelvic floor muscle dysfunction is a problem in the muscles at the bottom of the pelvis. It's either related directly to those muscles, or it's something that's being referred from the uterus, the ovaries, the bladder, or the rectum. It's something in the actual pelvis.
Okay. And what kinds of treatments would a women's health physical therapist do to help chronic pelvic pain?
Yes, there's a whole host of things, and if anyone's ever had physical therapy for any other joint other than the pelvis or pelvic floor, they've probably had these treatments in those areas. It's just that unfortunately the anatomy can sometimes make it where we do it a little bit differently, or makes people a little squeamish just because of the location. But we can do stretching just like muscles anywhere else, and that can be done in a variety of ways. Sometimes it's done with the therapist's hands. Sometimes, or most of the time, the therapist can teach that to the patient or a patient's spouse to help them with it if they're more comfortable with themselves or a loved one doing it versus the therapist. It can be done if it's really deep muscles in the pelvic floor. Sometimes dilators are used, especially if the person doesn't really want the therapist doing it. You know, they're okay with the education but then want to take control of the treatment, which, you know, then people joke, oh, so you're shopping at a sex toy store or something. No, they're medical supplies sold from medical supply companies. They're just plastic. They look like a tampon but come in numerous sizes, starting as thin around as a pen or pencil, and then getting, you know, even larger than a tampon, especially if someone's goal is to resume sexual intercourse.
Absolutely.
To stretch the muscles. You can use different modalities, which are things in physical therapy that help us just improve our odds of meeting the goal that we're trying to attain, which with pelvic pain, it's usually loosening up the muscles. So sometimes that's as simple as hot and cold, or it can be ultrasound, which is it's a way to get heat deeper. It does not get a picture like people, if they've ever had ultrasound as a diagnostic tool. It doesn't give any pictures, but there's a little crystal in the wand that's just gently massaged around on the muscles, and it can be done externally, actually, not internally.
Area usually?
Yep, in the vulvar area, yep. And that crystal vibrates off of the tissue and produces heat, but it goes past the skin. That's often the problem with muscles in many areas. A heating pad might help temporarily, but it doesn't get deep enough. It heats up your skin, and you feel that, and that feels nice, and so that helps with pain, but it's not getting deep into the tissue to really help the muscle relax, and so ultrasound does that. It goes deeper. It also helps increase blood flow by increasing the heat in the muscle, which brings more oxygen to the tissue, which also helps the tissue to heal.
Okay. I know. I've had ultrasound myself with you, and I thought it was very helpful. Did not hurt, was not uncomfortable, even when I had a lot of pain. I thought that was a really good option.
Yeah, it's a really light pressure, so even if people are having trouble in the pelvic floor, even into those layers just under the skin, because it's not a lot of force, like stretching can be, then sometimes that's a better place to start, to do that before the stretching, to help someone relax a little bit and make the stretching less painful. And the stretching isn't always painful, but sometimes it can be until you get the muscles calmed down. Another modality that we use is electrical stimulation, which sounds scary. That's usually one that makes people like, oh, it's great, she's going to electrocute me in therapy. But it's just a very subtle kind of tingly feeling. And that's because all of our nerves speak to our muscles via an electrical signal. And if you are feeling pain, even though the source of the pain may be in the muscle, it's coming from the nerve is the reason you're feeling it. So even if the nerve is not damaged or disrupted, the nerve is part of the problem. And so that's just a way to block that signal so that it's not getting to the muscle to give you the pain that you're having. And that we can use in the clinic. That can be done internally via the vaginal canal, or it can be done with surface little sticky electrodes that go on your lower pelvis over that sacrum, that triangle-shaped bone. The sacral nerves S2 through 4 control the pelvic floor, so that's a way to get to those muscles externally if someone's having too much pain to allow an internal sensor.
Is this the same as a TENS unit?
Yes,
okay.
A TENS unit is a way for you to do it at home. A TENS unit usually will just come with external sensors. If it's a standard TENS unit, there is a specific pelvic floor stimulator, which then only has an internal electrode. So unless I feel that someone really needs that internal stim and I know they can tolerate it, a regular standard TENS unit is best, because then you have more choice of how many electrodes to use in placement. And then if you're having a really bad pain day, you don't have to worry about trying to insert that sensor.
I had really good luck with a TENS unit, and I found they weren't real expensive, and then insurance did cover mine. I think in a lot of cases,
right,
insurance will.
Most of the time, insurance will cover them. Sometimes they make you jump through a few hoops where they might rent it for the shortest I've seen is a month, and then they want something from your physician or whoever referred you to physical therapy saying it's helping before they purchase it. The longest I've seen was 6 months, but all of the TENS companies that we have worked with will put, if your insurance does rent it, they'll put that price towards the purchase. So then it's not like, the insurance rented it and then they now have to buy the whole thing, which could deter them from doing it. Usually they apply that rental to the purchase price.
I was surprised at the expense of a TENS unit. I think mine was something like $500, and I was glad insurance paid for it, but still was a really good system to have. And I think you can use that in other ways. Can't you in the future if you have back pain or something like that? It's still...
Yes, you can use it pretty much anywhere that there's a nerve, which is our whole body. You can't put it on your head because it will mess with brain activity, and it's not good to put it over your heart because that can mess with the electrical activity in the heart. And if you have to have a pacemaker put in, you can't use it anymore. But otherwise, it helps with a lot of pain. Some people find that even putting the electrodes over their abdomen, really lower abdomen, helps with the pelvic pain too. That's not directly working on the nerves, but
depends on where your pain is, I suppose.
Exactly.
Another thing that you and I used was biofeedback.
Right, and
tell us about that.
Oh, biofeedback I think was a wonderful invention. It, again, can be used with surface or internal electrodes. If it's used with surface, it's mostly going to get the first layer of the pelvic floor muscles that are directly below the skin, versus an internal sensor will get both the surface and the deeper pelvic floor muscles, but both can be very beneficial. It's a great way for you to see what your muscles are doing, because you feel what they're doing all the time, and that can really overwhelm the senses, especially when it's there constantly, where sometimes it can get hard to tell anymore, what kind of pain is it, where exactly is it located. It just hurts, and it's there all the time. So biofeedback's a great way to see which muscles are more problematic and what they're doing, and try different ways to try and make them relax. I'm sure most people have probably heard of a Kegel or a Kegel, and that's just a contraction of the pelvic floor if you haven't heard of it. The man that found that the pelvic floor was under our voluntary control, his last name was Kegel, so it got named after him. It seems silly, but even if someone doesn't have weakness and is not having incontinence or any of those things, but they have pelvic pain and the muscles are in spasm, by doing contraction and relaxation cycles, a lot of times you can break that spasm cycle, almost confuse the muscle or work it to a point of exhaustion so it can't squeeze anymore. And so the biofeedback is a way to make sure you're getting a good squeeze, because that can be hard if the muscles are already tense because it's in spasm, and then to see how much you relax from that squeeze. And just getting that visual feedback helps a lot of people to relax more than they are at baseline.
Hey, is there a internal probe or something like that you use for biofeedback, or what's the actual mechanism that's used? I know there's a screen that you look at to see.
Yes, it hooks up to a computer system. There is both an internal and external set of electrodes. The internal is much more accurate, but again, if someone was not, the sensor is a little bit bigger than a super size tampon. So for some people, that's why you're there. You're having pelvic pain. Those muscles are in spasm, which means that there's that sphincteric function. They're going to make the vaginal opening smaller. So you might not be able to tolerate an internal sensor. So then a lot of times the external ones are used, which are they look like tiny little round Band-Aids that have a snap on them, and the snap hooks to the wires that connect to the computer to put the signal so you can see it. So that's definitely a place to start. And for the most part, people, if they're having severe pelvic pain where intercourse, things like that aren't possible, even sitting is painful, the internal sensor probably isn't going to work at first, and so that external is still going to give a lot of information because those muscles are tense as well. As people start to get better, a lot of times the surface muscles will get better, but the deep, or the levator ani, sometimes it's called, if anyone's done any research on the muscles, that group of muscles is deeper, and it can be picked up if there's a really strong spasm. It can be picked up by the biofeedback with the external sensors, but is really more accurately picked up by the internal. But I don't want to scare anybody off to physical therapy treatment thinking, oh, well, great, they're just going to make my pain worse. They're going to make me shove this sensor in my vaginal canal, and I already have pain there, and that's the whole reason I'm going there. There's many options, and that's not something that someone has to start with, and then that's a great goal to be able to get to that.
Sure, but it's even probably good just to have the external things to start with if you're
right.
having a lot of pain.
Exactly. If you're having a lot of pain that would make the internal, not able to work, you're going to get a lot of information from the external.
Awesome. That's going to be helpful to a lot of people. When I had a lot of pelvic muscle tension, I ended up going to a pain clinic for nerve blocks. Do you remember how we kind of integrated the nerve blocks in with the physical therapy, and it really seemed to help deaden the nerves so that my pelvic muscles were able to relax?
Right, exactly, and that goes back to the same concept of why the TENS unit can be helpful, because those nerves control the muscles. And so if you can get, even though a lot of times that's temporary and doesn't last forever, the nerve blocks, that's very variable though. Some people get months and months and months of relief. Some people just get a day or a week of relief. But if you then get your nerve block and then have your physical therapy treatment following that, you can often tolerate then a lot more stretching because you're not having as much pain because they've taken away that nerve stimulus. A lot of times they won't block all the nerves at once because then you could lose bowel and bladder control, and that wouldn't work. So it's definitely not a perfect solution. There usually is some pain, but a lot of times it's then much more tolerable. You can stretch a lot more of the muscles, or definitely have more internal work done usually, which can get to trigger points and things where you need to be touching the muscle to really make it better, which can be very helpful for therapy. Some physicians want therapy the same exact day as the block, and sometimes it's not until the next day, but then usually you have therapy daily for anywhere from 3 to 5 days, depending on which day the block happens and if they want you to start immediately or 24 hours later.
That was my experience. They would do a hypogastric or ganglion impart was the other one that I had, and then maybe do that on a Monday and then have physical therapy Monday, Tuesday, Wednesday, Thursday, to take advantage of the nerve block and the lack of pain, or the improvement in pain at least.
Right.
That was very helpful. Another question we had was, what would happen if you just left those spasm muscles alone and did not do physical therapy, just left them alone? Would they ever heal on their own, or is that something that without some help you're always going to have that pain in those muscle spasms?
I wouldn't say that it's impossible to get rid of with time and with healing. And if you're really good at just general relaxation, like if you know things that work for you to relax you in other areas, if you have a lot of stress going on, things you can do, some people it's a warm bath, some people meditate, some people do yoga. If you have a tool like that helps you relax in other areas, sometimes by doing that and then finding if just regular ice, heat, things like that work for you, and you put those tools into place, people can get better on their own. I would say just not doing anything, like just saying, okay, I'm going to let time pass.
Really, let time.
It's probably not going to get better. It needs some sort of tool to help it, but it doesn't necessarily have to mean physical therapy if you can find some other things. It also depends on how involved the muscles are and how many of the muscles, because the pelvic floor isn't one big muscle, it's groups of individual
I was
muscles.
going to mention that too. Like, how many are there that you would generally stretch if you're doing internal stretching?
There is 4. that we consider the external layer, and then there is 5 more deeper in the internal. Yeah, that's okay.
I'm not quizzing you, but
I have to kind of think of all the points. I go in my order when I do my evaluation.
But if I remember correctly, each one is different, and one can be in spasm, the next one can be loose, and they tend to loosen at different times. Strange feeling from the inside to have your muscles, some spasm, some not, and you feel kind of off balance.
Right. Exactly, because and the reason why they can each do that, even though collectively together they all have the same function, they all have different attachment points, and so that's why, and they're all controlled by the same group of nerves, but those nerves supply, the higher sacral nerves supply more the muscles towards the front of your pelvis, and then you go down there more the back towards the tailbone, and so that can be how they're different. Also, just general medical history, if you've had any other issues prior to the pelvic pain starting, like falling and breaking your tailbone, when you were 6 ice skating or something like that, that can sometimes have scar tissue or could have a muscle problem that maybe wasn't significant, something you didn't notice, but now that this has been put on top of it, now it's much more noticeable, so that can make certain muscles be worse than others.
Scar tissue, you mentioned, that's not one I had written down, but something we should probably talk about. Many of the women have had multiple surgeries, sometimes 5 or 6 surgeries, and there is a lot of scar tissue in there. And sometimes doctors tell us that our pain is because of scar tissue.
Right.
Is that possible, and what can physical therapy do to help with built-up scar tissue?
Scar tissue definitely can be a source of pain, and basically scar tissue is an abnormal tissue that doesn't have any contractile properties like muscle does. So now if you had to cut a muscle in order to repair something, or like when they remove the sling, because that is attached to muscle tissue, that scar tissue is not going to move and flex and stretch the way your muscle does. So then your pelvis is still meant to move. Every time you take a step or you go from sitting to standing or standing to sitting, the pelvis has to move. And so if that tissue is not moving, then it creates tension force, and then the muscle can want to go into spasm to try and protect you. Our body innately wants to protect us and not cause pain, but sometimes its defense mechanisms can actually make pain worse. And that's one of them, where everything kind of tightens up. And so a scar tissue can be stretched much like muscle tissue. Now it is not contractile like muscle, so it's more of a mobilization would be the technical term, meaning trying to move it around and break it up. So instead of having one, say you had a 2-inch incision on your lower abdomen from a previous hysterectomy that they had to do abdominally. Instead of having that 2-inch long incision that causes 2 inches of scar tissue, sometimes you can break it up into small pieces of scar tissue so it doesn't pull as much on the muscle tissue. And that's done with massage.
Internal and external.
Internal and external, depending on where the scar tissue is.
And it's usually around an incision, so if we have a vaginal incision, that's obviously where the scar tissue would start to form. And
right.
You can press on that, you can massage it. Can you do that yourself, or is it better to...
Nope, I often teach people how to do it themselves, just because any type of stretching, whether it's a scar mobilization or massage technique or stretching of a muscle, the more frequently it can be done within reason. I mean, you can overdo it and cause more irritation, but the better. And stretching in general, it's best to be done daily if possible.
Okay.
If pain allows.
Well, even if you're going to physical therapy during the week, it's nice on the weekends to have the knowledge to do some of that yourself. So
exactly. And chronic inflammation can also cause scar tissue, so it doesn't always have to be in an area of an incision. That's the most common place to find scar tissue, and that's where sometimes pre-existing conditions can become problematic. Polycystic ovarian syndrome, for example, is a problem where people get a lot of pelvic inflammation just from that disease, and so if that was something that was, pre-existing, they might already have kind of a scar tissue built up in the pelvis. That condition itself tends to have pelvic pain.
Tendency to develop scar tissue.
Yep, exactly. So then that can make scar tissue in the muscle in random places just from inflammation sitting there too long. So it can happen from other things. Mostly it's around incisions, though.
Okay. Teresa, do you have any other questions on these areas before we move on to other things?
Actually, no, I'm good. I actually have one question. This is going to sound kind of a corny question, so I apologize, but it's something I think some women are concerned about. Is it abnormal for a woman to become, while you're maneuvering, to become sexually aroused? Is that something that you see? Because some women actually are very uncomfortable about that, and that's the feedback I've gotten. Is that something that you've dealt with, or is it normal?
It can. I won't say that it's abnormal, although it does not happen frequently. It would be perfectly normal for that to happen because if we go back to when we talked about the pelvic floor muscles and their 3 jobs, which were all S's, the third one is sexual function. They definitely are involved in that. Usually, especially when pain is so severe, it's very hard to put those muscles into arousal because they're in such a spasm, but it can happen. They also take great care when we learned all of our stretching techniques where to avoid putting pressure to not arouse someone. Because sometimes you might really be focusing on stretching a muscle with, say, your index finger, and your thumb is just kind of hanging out outside of the vaginal opening, and next thing you know, it's resting on the clitoris. So they did a lot of education, hand placement and things to do to try not to accidentally cause sexual arousal. Not, of course, a therapist is not trying to do that at any time, but just to avoid that because that does make people uncomfortable. But even if it just happened, even if you were working on some trigger points in those deeper muscles and you cause that spasm to break, sometimes people can become aroused by that because of just the sensation of that muscle finally relaxing. That would not be an abnormal thing and shouldn't be something that someone worries about. I mean, that's not something the physical therapist is probably even going to mention unless the patient says, "Oh my gosh, what just happened? It felt like I was sexually aroused, like I was having an orgasm, and I mean, you're stretching me." So unless the patient brought it up, the therapist probably would just not even mention it to avoid embarrassing someone or making them, feel guilty or nervous or anxious about having stretching done again. A lot of times, to be perfectly honest, if you can get the muscles to orgasm, that helps.
I was going to ask, yes. So a lot of women asked about what if they orgasm during physical therapy, or is it a good thing to have an orgasm if you can? And I know that's a form of stretching.
Right. It is a form of stretching, and often it's one of those sometimes harder things, and I don't want to say that I give people that it's homework, so to speak, but that can be part of a home program, like see with your partner or spouse if you can, cause yourself to get aroused at all, because that if you can get yourself to have an orgasm, that can be therapeutic for the muscles and help them get better.
Well, thank you. That actually answered my next question, so we got that covered. I try to ask the questions that other people may want to ask but are afraid to ask.
Absolutely. That's exactly the question I've been getting all week, too. I think that's a big one for people. So.
Well, I thank you very much for answering that question. That's the only ones that I have, and I really want to thank you.
That's her main one, so. Okay, we are going back to talking a little bit about Kegel exercises.
Sure.
And you had some statistics here on your outline?
Yes.
Go ahead and go over those.
I always liked, and actually it's gotten better. Some of the newer research, the statistics are a little better on what they used to be when I first started studying this. So that's a good thing. I hope that means people are becoming better educated. But 49% of women, only 49% of women, after being given just verbal instruction on how to do a Kegel, can do it correctly, which means that 51% of people, women, are doing them incorrectly. And that is very frustrating to me because I don't know how many times I will have a patient show up for their evaluation and I, go through some of the things just like we've talked about of what I'm going to do, how I'm going to evaluate them. And as soon as I mention Kegels, I see this glazed look come over them and they tell me, been there, done that, that's not going to help. And so, well, that's why, because 51% of people have been wasting their time and doing them incorrectly. And in fact, 25% of that 51% of women will contract their muscles in a manner that could actually make their symptoms worse. And that's the most alarming part, because if you've been told by your physician, maybe they didn't know physical therapy was available, or maybe you decided you didn't want to try that right now, or whatever the reasons for not being sent to someone who can teach you how to do them correctly, you just thought, I'm going to try them on my own. And there's no harm in that. But if you're doing it wrong, if you're that 25% of women, then you're actually making your problem worse. How excited are you going to be then to go to physical therapy? Because in your head you didn't know you were doing them wrong, and now someone tells you, well, that didn't work, you're going to have to go to physical therapy so they can help you. Well, you're not going to want to, because you're going to think, well, I just spent all that time doing them and it made it worse. What is physical therapy going to do? So that is alarming to me. The hardest part is they're very deep muscles, and there's nothing that you can see to know that they're working correctly unless you're hooked up to biofeedback. So when someone just tells you, well, squeeze those muscles at the base of your pelvis, the ones that stop you from urinating. Oh, okay, great, clear as mud. If someone tells you to do a bicep exercise, you know after a little bit of a direction where they tell you where the bicep is and what the bicep does, you know that by curling your arm and bringing your hand towards your shoulder, bending your elbow, okay, you know what to do. You can draw a picture of that. Someone can write you directions on how to do that. There is not a way to draw a picture of the pelvic floor muscles contracting so you know how to do a Kegel. And there's not great directions either. So that's why I think that statistic is so high, although it has decreased. It used to be 65% of women did them wrong, so we're getting a little bit better. The best way that I can give people without having a physical therapy evaluation done to know if you're doing them correctly is when you urinate, try to stop yourself midstream is probably the easiest, least invasive way. However, that is not where Kegels should be done. If you consistently, like every time you go to the bathroom, try to stop your flow of urine, you will confuse your bladder, and that leads to incomplete emptying, which can lead to bladder infections, which just can cause more pain. Another way is to actually insert your finger vaginally, and you should be able to feel the muscles squeeze around your finger. That's usually one that people are, not as comfortable doing, but that's probably the best way. That's your own built-in biofeedback.
Your finger dilator.
Exactly. Yeah, exactly. So that you're squeezing onto it. And especially if people are having pelvic pain and it's because the muscles are shortened, tightened, or in spasm, or all of the above, it can be hard to make them contract because they're already in a state of contraction.
They don't want to let loose. They're stuck. I always felt.
Exactly. Another nice statistic, though, is that 85% of women who have pelvic floor muscle dysfunction, whether it's weakness, tightness, incoordination of the muscles, find significant improvement in their symptoms after treatment by a women's health physical therapist. And that just shows that, with just a little extra instruction or guidance or the biofeedback, that you can make those Kegels correct and then see the fruits of your labor, so to speak, and find an improvement.
I think that's a great statistic. 85% of women find significant improvement, and we're all looking for that. We're all looking for something to reduce our pain.
Right.
So I would like to encourage everyone to try physical therapy. I had wonderful results with it. And I think it's a good avenue to go. It's non-invasive and inexpensive and a good place to start for a lot of people. So, Teresa, do you have any other questions?
No, I'm good. This was fabulous. Thank you so much, Jessica and Janet. I really appreciate this.
We talked for a whole hour. Edit that. All right, well, I think we've covered every area of pelvic floor physical therapy that we were interested in covering today. And if there are no more questions, we will bring this call to an end. So on behalf of the administration and members of TVT-NO, I'd like to thank Dr. Jessica Aubert for sharing her expertise with us today. Thank you so much, Jess. It's helped many, many women. Hundreds of women will listen to this and be helped, I know. So
my pleasure. I hope that even a little bit of knowledge is power to get treatment and get relief of pain. I just also wanted to add that if anybody ever has any questions about anything, a phone call is sometimes hard for me, especially if there's a time difference depending on where someone is.
Okay.
But my email, anybody, if it's something that I can try and answer over email, I would be glad to do that. And my email is jaubert@bamc.org. And I'd be, if it's something that I can answer without having to do an evaluation or try and help someone find a provider if they're having trouble with the website that might be close to them, I would be happy to do that.
That's a very generous offer. We appreciate that, and we will put that email address along with this recorded call so that everyone can take advantage of that and contact you. So,
all right.
Okay, well, thank you very much, Jessica. Everyone,
Thank you.
we're done.